pulmonary alveolar proteinosis. So this is the defect here is surfactant clearance impairment. Because of some disease, surfactant is not getting cleared properly from your body. Surfactant clearance impairment. Surfactant clearance impairment. Now what are the cells responsible for production of surfactant, students? It will be your type 2 pneumocytes. Removal, alveolar macrophages. Here the problem is in removal, problem must be in alveolar macrophages. Coming to the etiology, it can be classified into two forms. A primary form, this is the most common form, students. Then we have a secondary form. Primary form generally happens because of autoantibodies against granulocyte, macrophage, colony stimulating factor, also written as GM-CSF. This GM-CSF is responsible for proper formation of alveolar macrophages, students. If this factor is not available, your macrophages will not be formed properly, surfactant will not be cleared properly. Then coming to secondary form. Secondary form generally happens because of acute silicosis. It happens because of acute silicosis. Now how is silica particle responsible for pulmonary alveolar proteinosis? Silica particles toxic to alveolar macrophages, students. Silica particles toxic to alveolar macrophages. Whenever somebody inhales huge amounts of silica in short duration of time, it is called as acute silicosis. Because of this silica particles entering in your lung, it will not allow alveolar macrophage function properly, and because of that surfactant will not be cleared properly. Now with this background, when a patient is exposed to silica for long duration, chronic silicosis, what is the infection that can happen in his lungs? Yes, students, guess what infection will happen? Against which infection alveolar macrophages are considered as first line of defense in your body? Tuberculosis. That's why this entity is called as silicotuberculosis. What happens in tuberculosis generally? Whenever alveolar macrophages, the first line of defense, is not working in your body, TB bacilli can easily proliferate. In silicosis also what can happen? These silica particles will not allow alveolar macrophages to function properly. The first line of defense is getting affected. So ultimately what can happen? There will be easy proliferation of TB bacilli and active disease. So chronic silicosis, the entity is called as silicotuberculosis. Now coming to the pathophysiology, consider this is your alveolus. Into this now excess surfactant is getting filled. Point to remember here is surfactant is a white colored substance. Surfactant, the physical property, it is a white colored substance. Now your lung is filled with excess white colored substance called as surfactant. Because of that, oxygen cannot penetrate this fluid and go into the blood. There will be decreased transfer of oxygen. That will result in hypoxemia. Now coming to the diagnosis. So diagnosis, there are three important findings. When I put my bronchoscope into the lung and get some sample, what is this called as? Bronchoalveolar lavage. Now your lung is filled with white colored substance. So if you put a bronchoscope and suck out the secretions, it will be white. Bronchoalveolar lavage will be milky white. And if I subject this bronchoalveolar lavage to a special stain, because of its contents, it will be PAS positive. PAS is nothing but periodic acid skiff stain. And CT chest will show a classical pattern called as crazy paving pattern. What is crazy about this pattern we will discuss in the next slide. Then coming to the treatment, the simple logic here is your lung is filled with excess whitish colored fluid not allowing oxygen inside. What will be the ideal treatment? Put a bronchoscope inside and suck out all the excess whitish fluid. This phenomena is called as whole lung lavage, students. It is called as whole lung lavage. Now if it is a secondary form, you do whole lung lavage and you ask the patient not to get exposed to the silica, the treatment is over. Whereas in primary form, even after doing whole lung lavage, after few weeks again surfactant can reaccumulate. Now in reaccumulation and recurrences also, the treatment of choice is whole lung lavage. Primary form, it can recur, and during recurrences also the treatment will be whole lung lavage. Now let us see the important diagnostic features, the pictures. What do you see in this first picture, students? It is milky white bronchoalveolar lavage, milky white bronchoalveolar lavage. Before going into the classical CT chest finding, first see this image. Now if you go to a park, you can see the pavement where generally people walk. What you can notice there? You can notice polygonal shaped stones arranged in an irregular manner. Polygonal shaped stones arranged in an irregular manner. Because it is pavement, it is called as paving pattern. Because stones are arranged in an irregular manner, it is called as crazy. It is called as crazy paving pattern. Now the person who has first identified the CT chest finding in a patient with pulmonary alveolar proteinosis was very much obsessed with parks. He felt that lung architecture was also looking like polygonal shaped structures arranged in an irregular manner. Now see here, students, the similarity between these two images. Are these two images looking similar? Yes. That's why it was called as a crazy paving pattern. You can notice. So this image of CT chest is similar to this pavement. It was called as a crazy paving pattern. So this is the classical finding. Now why will the lung predominantly appear white like this, students? Why it is appearing white? Because normal lung contains air, normal alveoli contains air, it will appear black. But here instead of air there is excess surfactant. So point to remember is this is a bilateral whitish abnormality, bilateral whitish abnormality, and the classical pattern is crazy paving pattern. And you see milky white bronchoalveolar lavage, and in the cytology there will be PAS positive nature. So these are the important findings. Crazy paving pattern, milky white bronchoalveolar lavage. Crazy paving pattern, milky white bronchoalveolar lavage. Next let us see the Weibull's lung model and regarding aspiration and bronchiectasis. Before that we will see a question. Case 2, a 39-year-old male stone crusher. So this is the stone crusher that we know. So whenever they mention stone crusher, think about his exposure to silica. Presented with progressive dyspnea on exertion for 5 months, long-standing cough with whitish sputum. No fever, chills, weight loss, night sweats or other symptoms. Patient undergoes bronchoscopy. It is milky white and you can see PAS positive staining. What is the diagnosis? When you say silicosis in the history, milky white bronchoalveolar lavage, milky white bronchoalveolar lavage, along with that PAS positive, if that fluid is PAS positive, all these are suggestive of pulmonary alveolar proteinosis. Your direct answer should be pulmonary alveolar proteinosis. Now why it is not tuberculosis? Because there are no classical signs of tuberculosis. Why can't it be community acquired pneumonia? Generally community acquired pneumonia is an infective manifestation with fever, cough, shortness of breath, chest pain, usually acute presentation. Now, why it is not silicosis? Because silicosis is not the reason why the patient has come to the hospital. Silicosis is the risk factor here, responsible for pulmonary alveolar proteinosis. It is just like a patient with obesity has come to the emergency department with chest pain. You found out he is having MI on ECG. Now, what will be the diagnosis? Is it obesity or myocardial infarction? So, what will you treat there? Will you just write on the case sheet that this is obesity, because of obesity he developed myocardial infarction, so I will treat only obesity, diet restriction, weight reduction, go home. It is not like that, students. You have to treat the complication. So, working diagnosis there will be myocardial infarction due to a risk factor called as obesity. In the same way here also, the diagnosis is pulmonary alveolar proteinosis and it is due to a risk factor called as silicosis. So, the answer will be pulmonary alveolar proteinosis. Then coming to Weibull's lung model, how trachea is finally giving rise to alveoli. If you consider your airway as the family, large central airway called as trachea finally gives rise to tiny structures called as alveoli. In this division there are about 23 generations. If you consider trachea as the ancestor, alveoli will be the great 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 granddaughter or grandson. So, you need to know Weibull's lung model mentions that large central airway finally gives rise to tiny structures called as alveoli, and in this division there are 23 generations. Let us see the important generations. First, the large central airway called as trachea. Trachea. It gives rise to a right main bronchus and a left main bronchus. A principal bronchus. It gives rise to a principal bronchus. From each principal bronchus, there will be corresponding lobar bronchus. You must be knowing this, students. On right side, how many lobes are there? 3 lobes. 3 lobes on right side. On left side, only 2 lobes. Then from each lobar bronchus, there will be segmental bronchus. There will be segmental bronchus. From segmental bronchus, there can be multiple divisions, later on giving rise to a terminal bronchiole. After multiple divisions, there can be terminal bronchiole. Terminal bronchiole. Now, from the terminal bronchiole, there are tiny divisions. There are tiny divisions called as respiratory bronchiole. Tiny divisions called as respiratory bronchioles. So, these are the respiratory bronchioles. From the respiratory bronchioles, we have again ultimate divisions called as alveolar duct and alveolar sac. This is called as alveoli. From the respiratory bronchiole, you will have alveolar duct, alveolar sac. This is called as your alveoli. These are alveoli. This is how a large central structure called as trachea finally gives rise to tiny structure called as alveoli. For your exam, they are going to ask in this division up to what level is considered as dead space. This is the first question. And what is considered as functional unit, ventilatory unit, also called as acinus, These are the questions that they ask you. In this division, up to what level is considered as dead space? What is meant by dead space? Dead space means there will be ventilation but no gaseous exchange. In my lung, up to terminal bronchiole. The answer for this question is up to terminal bronchiole. Up to terminal bronchiole there will be ventilation but no perfusion. Now beyond terminal bronchiole, the important function of lung called as ventilation happens. The important function of lung called as ventilation happens. This area distal to terminal bronchiole, this area distal to terminal bronchiole, where the important function called ventilation happens is called as acinus, and ventilation predominantly happens at the alveoli. It starts distal to terminal bronchiole and it predominantly happens in the alveoli. Now how is this clinically important for me? There is a disease called as emphysema. Now which part of lung is involved in emphysema? Which part of lung is involved in emphysema? What should be your answer, students? Which part is involved? Emphysema, the definition is destruction. It is destruction distal to terminal bronchiole. Destruction distal to terminal bronchiole. What is the part distal to terminal bronchiole? It is acinus, because acinus is getting involved. When you are learning in pathology types of emphysema, what are they? Centriacinar emphysema, panacinar emphysema, distal acinar emphysema, because this is the acinus getting involved. So there is destruction distal to terminal bronchiole, and what is the structure there? Acinus. Because the gas exchange areas are getting destroyed in emphysema, these patients generally will have impaired gaseous exchange. Gas exchange areas are getting involved. So the patients will usually have impaired gaseous exchange. There will be impaired gaseous exchange. And very, very important, students, this is the reason, because gaseous exchange is not happening properly. Patient has to take more and more breathing for gaseous exchange to happen. Because he is taking more and more breathing, he will have respiratory discomfort. Tachypnea can happen in emphysema. Up to what level is dead space? Up to terminal bronchiole. Distal to terminal bronchiole is acinus. Emphysema, destruction distal to terminal bronchiole. So that is responsible for impaired gaseous exchange in emphysema. Impaired gaseous exchange in emphysema. Now let us see on which side aspiration is common, on which side bronchiectasis is common in the lung. You know there is right main bronchus, left main bronchus. Let us see on which side aspiration and bronchiectasis will be common. So write down BXIS means it is short form of bronchiectasis. Wherever I write BXIS, it is bronchiectasis. Now let this be the large central airway called as trachea. And this trachea, as I told you, it gives rise to a right main bronchus and a left main bronchus. A left main bronchus, a right main bronchus and a left main bronchus. When compared to the left, the right main bronchus tends to be, short, stout and straight. It tends to be short, stout and more straight. Because of that, any fragment falling into the trachea, the tendency is to reach the right. There will be increased chances of aspiration. There will be increased chances of aspiration on the right. Increased chances of aspiration on the right. Now whereas your left main bronchus is narrow. It is narrow, angulated and decreased drainage of secretions Now for example, if any secretions reach to the right lung, So it is easy to reach the right lung, and if the patient is having a good cough reflex, he can also easily expel the secretions out. But if anything unfortunately reaches the left lung, it is very difficult to clear. It is going to stay there. There will be stasis of secretions resulting in obstruction. Whenever there is stasis and obstruction, it will attract infection. Infection will result in inflammation. Because of this infection and inflammation, there will be damage to muscle and elastic tissue of airway. So there will be destruction of muscle and elastic tissue that result in dilatation of airway. Destruction and dilatation of airway. So these destroyed and dilated airways are nothing but bronchiectatic airways. So whenever there is stasis and obstruction, it will attract infection and inflammation. Because of that inflammatory damage, there will be destruction of muscle and elastic tissue of the bronchus. See, muscle and elastic tissue are the structures keeping the bronchi firm. Whenever they destroy, the bronchi can abnormally dilate. So this abnormal dilatation is called as bronchiectasis. Now we know that there is left upper lobe and left lower lobe. Out of these two, which is frequently involved in bronchiectasis? See, if the secretions pull up in the upper lobe, if patient is having a cough reflex, good cough reflex, he can still expel out. But if it pulls up in the lower lobe, it is very difficult for the patient to cough out those secretions. So the answer, lower lobes more commonly involved. Lower lobes more involved. Lower lobes more involved. So what we have learnt here, students, on right side aspiration is common, on left side bronchiectasis is common, and that too on the lower lobes bronchiectasis is more common. Now we know that on the right side aspiration is common. On the right side aspiration is common. Now in the exam they will ask you with respect to patient's position. If patient is in supine position, what will be the precise bronchopulmonary segment involved? If patient is sitting or standing, what will be the precise bronchopulmonary segment involved? So write down aspiration pneumonia with respect to the bronchopulmonary segments involved. Aspiration pneumonia with respect to bronchopulmonary segments involved. Now the questions that they are going to ask you is, what will be the most common segment involved in aspiration pneumonia? Most common segment involved in aspiration pneumonia overall. Overall, what is the segment? In supine position, what will be the segment? In sitting, standing position, what will be the segment? So what will be the most common segment involved in aspiration pneumonia overall? So overall, what is the segment? In supine position, what is the segment? In sitting, standing position, what will be the segment? So the basic concept that you need to know here is, for overall and supine position, the answer will be the same. What is the reason behind this? Very simple, students. In whom aspiration pneumonia frequently happens? So in patients with impaired neuromuscular reflexes. When somebody's nerves and muscles are not functioning properly, will they be actively moving or will they be bedridden? They will be bedridden. Whenever they are bedridden, what is the position that they generally choose? They choose supine position, because aspiration pneumonia frequently happens in bedridden patients, and bedridden patients are generally in supine position. The answer for overall and supine position will be the same. The answer for overall and supine position will be the same. The simple logic is, aspiration pneumonia frequently happens in bedridden patients, and bedridden patients are generally in supine position. Now to understand this, you should know the anatomy of right lower lung. So how many bronchopulmonary segments are present in right lower lung? 5 bronchopulmonary segments. That is, right lower lung in the sense right lower lobe. So in the right lower lobe. So what are the bronchopulmonary segments? Here there is medial segment. This everything will be superior segment, anterior segment, lateral segment and posterior segment. So this is the lung. So you can notice here lung with 3 lobes, upper lobe, middle lobe and lower lobe. For you to understand the bronchopulmonary segments, I am taking the lower lobe of the lung out. So right lower lobe. So let this be the right lower lobe and right lower lobe bronchus, and these are the various segments. So these are the various segments. You can see this is the superior segment. So this division of bronchus gives rise to superior segment. This will be the superior segment. If you see side on, the segments will appear like this. So this will be the medial segment. This is anterior segment. So anterior segment. This will be the lateral segment. This will be the lateral segment, and this will be the posterior segment. This will be the posterior segment. So 5 segments in the right lower lobe: superior segment, medial segment, anterior segment, lateral segment and posterior segment. Now let us see according to patient's position. Now if the patient is sitting or standing, so when he is sitting or standing, this will be the position of his lung. So when he is sitting or standing, so this will be the position of this lung. Now whenever he is sitting and standing and he aspirates, so let this be the foreign body. See, foreign body coming into the lung is aspiration. So aspiration means anything falling into the lung. Anything falling down has to follow one important property called as gravity. So this is the foreign body. So it generally, with respect to gravity in sitting or standing, which is most dependent, this part. So when the patient is sitting or standing, the lung anatomy will be like this. So the object will fall down directly into the right lower lobe posterior segment. So when sitting or standing, this will be the anatomy of the lung. So when he is sitting or standing, the object will directly fall into the right lower lobe posterior segment. Now if you make the patient lie on supine position, or if the patient is in supine position and he aspirates, see, when I am sitting or standing, this part is the most dependent part. So this is very nearer to the ground. So by gravity, this is most dependent part. Whichever is nearer to the ground, to that part the foreign body will reach. Now in supine position, so whenever I lie down in supine position, you also try, the part adjacent to the scapula, the part adjacent to the scapula will be more dependent. So when you lie down, so the part adjacent to the scapula will be more dependent. So what are the segments adjacent to the scapula? So what is the segment here? The segment is right lower lobe superior segment, and some part of right upper lobe posterior segment can also be felt here. So write down, whenever patient is in supine position, whenever patient is in supine position, this portion, so I have shown you in this also, this is the right lower lobe superior segment. So this is the right lower lobe superior segment. So when he lies down, this portion is closer to the ground. So what is this segment? Right lower lobe superior segment. So this segment is right lower lobe superior segment. Along with that, some portion of this area. So what is this area? It belongs to right upper lobe, and what is present there? It is the posterior portion. So very simple, it is right upper lobe posterior segment. So if patient is sitting or standing, no confusion, it falls into the lowermost part, that is right lower lobe posterior segment. When he is in supine position, the part near to the adjacent to the scapula will be touching the ground. So what are those segments? Right lower lobe superior segment predominantly. If it is not given in the option, right upper lobe posterior segment. Very simple. If it is supine position, your answer should be superior segment. If it is supine position, Your answer should be superior segment. Your answer should be superior segment. That is the concept. If it is sitting or standing, it is posterior segment. Very simple. Patient is sitting or standing, right lower lobe, posterior segment. If he is lying down, now this part becomes dependent. What is present here? Majority of right lower lobe superior segment, right lower lobe superior segment, and some part of right upper lobe posterior segment. Now generally these aspirated substances can be foreign bodies. So whenever you can see the foreign body very clearly on the chest X-ray, these foreign bodies are called as radio opaque foreign bodies. If you can see the foreign body clearly on the chest X-ray, this is called as radio opaque foreign body. This was one of my case, a 45-year-old female. A 45-year-old female. She recently had a dental implant. Next day morning when she woke up, her dental implant was missing. She came to me. I have taken a chest X-ray. What is this chest X-ray suggest you of? So 45-year-old female, she had a dental implant recently. Next day morning when she woke up, there was no dental implant in her oral cavity. She came running to me. I have taken a chest X-ray. What do you see? Can you see on the chest X-ray, students, an opacity similar to dental implant? Yes. So such foreign bodies which can be clearly seen, whose opacity can be clearly seen on a chest X-ray, they are called as radio opaque foreign bodies. So what must have happened during her sleep? That dental implant must have been dislodged and it must have gone into her lung. She must have aspirated. So such foreign bodies that can be seen clearly on a chest X-ray are called as radio opaque foreign bodies. Sometimes there will be foreign bodies, but you cannot appreciate the density on the chest X-ray. Such foreign bodies are called as radiolucent foreign bodies. Now let us see the common radio opaque foreign bodies. You everybody know radio opaque foreign bodies: coins, pellets, metals and teeth. So common radio opaque foreign bodies: metals, teeth. Teeth is also a radio opaque foreign body. Coming to radiolucent foreign bodies, students, can you tell me the example of radiolucent foreign bodies? Example is food particles, wood, plastic. So food, wood, plastic. So the concept here is whenever the foreign body is radio opaque, life is very easy. You know where exactly the foreign body is present. You can put your bronchoscope and you can retrieve the foreign body. But whenever it is a radiolucent foreign body, it requires some clinical examination and some clinical skill in suspecting that there is a foreign body. So let me give you another case scenario and let me see how are you going to identify. So this was a 35-year-old male patient. His wife was out of town, so he had a alcohol party at home and he aspirated. He had an alcohol party at home and he aspirated. So whenever they mention patient is an alcoholic, always think of aspiration. So there is aspiration history in this patient. He came to my emergency department. This was the chest X-ray. So chest X-ray, what is it showing? Chest X-ray, what is it showing? This is right lung, this is left lung. Now if you see, left lung is completely open. Left lung is completely open. It is totally aerated. Whereas right lung, you can notice a well-defined homogeneous density. Such well-defined homogeneous density on a chest X-ray is called as collapse. So chest X-ray is suggestive of collapse. When you find these two in combination, what should be your suspicion? So what must have happened? So this patient must have aspirated some foreign body. So whenever the foreign body is large enough, it will occlude the bronchus. So whenever bronchus is occluded, so distal to that foreign body there will be less air. After some time no air. any airless lung field on chest X-ray is called as collapse. So when you see these two in combination, aspiration with collapse on chest X-ray, your suspicion should be foreign body. What must have happened? The foreign body must have gone lodged into a bronchus. So because of that, there should have been bronchial obstruction. So distal to that, there will be less air. After some time, no air. Any airless lung field is called as collapse on chest X-ray. You can see, because there is no air at all, that area will appear very, very white. So aspiration history with the collapse on chest X-ray, your suspicion should be foreign body. And what will be your next or best step? So next or best step, your answer should be scope is the only hope. So bronchoscopy. So why I consider bronchoscopy as the best step? The reason is, it will not only visualize the foreign body, we can also retrieve the foreign body. So this is actually a real life case scenario. When this patient came to my emergency department, I also suspected it to be a foreign body. Immediately I have done a bronchoscopy. I will show you the bronchoscopy video now. So this is the bronchoscopy video. You can notice, this is the foreign body within the bronchus. So I am doing the bronchoscopy here, and ultimately I could retrieve the foreign body. Can anybody guess what exactly is this foreign body? It is actually aspirated chicken liver piece. This patient was so much drunk, instead of putting it into his stomach, he has put it into his lung. So what is the moral of this story, students? Drink responsibly. Don't aspirate and waste alcohol. So this fellow don't know how to drink properly. He aspirated and created lot of mess. And after recovery, when I went and spoke to him, he was not worried that he was admitted in the hospital. He was worried that his wife is going to come to the hospital. So all these tragedies can be prevented if you drink alcohol properly by not aspirating it. But this is not what you should remember for your exam. So what you should remember for your exam is, whenever there is a clinical scenario like this, aspiration history with the collapse on chest X-ray, your suspicion should be foreign body and your investigation should be bronchoscopy. So this is a thing that you should imprint in your mind. Aspiration history plus collapse, suspicion is foreign body, investigation will be bronchoscopy. Try to solve this question. Case number 3. A bedridden patient on liquid diet develops aspiration pneumonia resulting in a lung abscess. Which of the following bronchopulmonary segment is most likely affected? Students, whenever they mention bedridden patient, he will be in supine position. Because of aspiration, later on he developed lung abscess. So if you see this in combination, aspiration plus supine position, what should be the segment? I told you, right lower lobe superior segment. If it is not given, right upper lobe posterior segment. Check for this in the question. Can it be left upper lobe? No. Left lower lobe? No. Posterior segment of right lower lobe? No. So this will be in sitting or standing position. But here patient is bedridden, so supine position, right lower lobe superior or right upper lobe posterior. So the best answer will be posterior segment of right upper lobe. Why it is? Many students will get confused with option D. Option D happens in sitting or standing position. Option A, it is the second best answer. Best is right lower lobe superior. If it is not there in the option, you can go for posterior segment of right upper lobe. Posterior segment of right upper lobe. Now what is this symptom in respiratory medicine called as, students? This symptom in respiratory medicine called as, it is hemoptysis. So this is hemoptysis, blood in sputum, it is hemoptysis. Let us discuss regarding hemoptysis in detail. Now your lung has dual blood supply. My lung is having blood supply from two sources. So what are those two sources? So one is a high pressure systemic circulation. One source is from the systemic circulation, high pressure systemic circulation, and the artery is bronchial artery, and the artery is bronchial artery, and other is the low pressure pulmonary circulation, the low pressure pulmonary circulation, and the artery is pulmonary artery. The blood supply to your lung is two sources, one is bronchial artery and other is pulmonary artery. Now let us see most commons. What will be the most common source of hemoptysis and what will be the most common source of massive hemoptysis? Now tell me, students, there is a low pressure circulation and a high pressure circulation, which has more tendency to rupture? Because there is a high pressure within the bronchial artery, it will have more tendency to rupture. So whenever it ruptures, it is rupturing at very high pressure. So it will be very difficult to control the bleed. So this patient may have massive hemoptysis. So the answer for most common source of hemoptysis and massive hemoptysis will be bronchial artery. The reason is high pressure within the circulation. Then what is the definition of massive hemoptysis? Massive hemoptysis means patient is expectorating more than 100 to 150 ml of blood per single episode, or more than 400 to 600 ml of blood per day. If in a single episode patient is expectorating about 100 to 150 ml of blood, it is massive, or throughout the day it is about 400 to 600 ml, then also it is called as massive hemoptysis. Then what is most common cause of hemoptysis in India worldwide? Whenever I say India, you should be knowing about our national disease. What is our national disease? Say it loud and proud. That is tuberculosis. Just like national animal, national bird, it should be given the status national disease. Then what is the cause of hemoptysis worldwide? Previously they thought it was due to malignancy, later they changed it to chronic bronchitis, but recent edition of Harrison has realized and it has given it as tuberculosis only. The simplest reason is we Indians nowadays are worldwide, and it will be our responsibility to spread our national disease. See, we share everything in Facebook, WhatsApp, Insta. In the same way we are sharing our national disease with a lot of pride. So let it be India or worldwide, it is tuberculosis. Then what is most common cause of massive hemoptysis? Recent studies have shown it is due to bronchiectasis. Then what will be the most common cause of death in massive hemoptysis? Why will a patient with massive hemoptysis die generally? It is not due to blood loss and shock commonly. Before that, something can happen that can kill the patient. What is that? For example, whenever there is massive hemoptysis, lot of blood in your lung, so blood can reach your trachea. Whenever blood is out of blood vessel, there is a tendency to clot. So that clot can occlude your trachea. See here, students, For blood loss to happen, shock to happen and patient to die, it will take about 10 to 15 minutes. If somebody tightly holds your neck, for how much time you can survive? Not more than few minutes. So that clot can cause asphyxiation and death. The answer is asphyxiation with blood clot. Most common cause of death in massive hemoptysis is asphyxiation with blood clot, and what will be the most important in management of massive hemoptysis? So the options given will be airway and circulation. Generally both are important, but when they ask you to choose one option, you should make sure patient's airway is free from blood clots. Most important in management of massive hemoptysis. Single best answer will be airway maintenance. Very important, students. Death in hemoptysis generally happens because of asphyxiation with blood clot. Most important in management is maintaining the airway. It is airway maintenance. So this is the introduction regarding hemoptysis. Now let us see the etiology of hemoptysis. Like I say always, when you are knowing about hemoptysis, you should know about patient's clinical history. Because of clinical history, you can avoid so many unnecessary investigations, students. So in etiology of hemoptysis, majority will be belonging to infective or neoplastic group. So if I am seeing 100 cases of hemoptysis, 70 to 80% will be belonging to this group. Either there will be an infection or there can be some possibility of malignancy. Less common groups are cardiovascular causes, systemic causes, traumatic causes. Traumatic cause generally my surgeon friend will take care. Up to systemic cause I am going to take care. Whereas this cardiovascular and systemic cause, they are usually minority group of hemoptysis. Majority, it is due to infective causes only. What are all the infective causes? So first in the list will be the national disease, tuberculosis, other bacterial infections, viral infections, fungal infections, infection of the bronchi, bronchitis and bronchiectasis. In bronchiectasis there will be recurrent infection resulting in inflammatory damage to the airways. So in the airways there will be blood vessels. Because of this damage, the blood vessels can erode resulting in hemoptysis. Then neoplastic, it can be either primary tumors of lung, because of primary tumors of lung, or due to some metastasis from elsewhere. Whenever you have taken a proper history and you are thinking that this belongs to the majority group, what will be the investigations? So how will you approach? So the investigations will be a complete blood count you will do to see what is his hemoglobin. Then you can go for a sputum examination to look for any organisms, cytology for any malignant cells, a chest x-ray. If nothing is properly visible on chest x-ray, you can go for CT chest for precise anatomical location, and eventually you can go for a fiber optic bronchoscopy, diagnostic bronchoscopy, fiber optic bronchoscopy or flexible bronchoscopy, so written as FOB. So this is the simple algorithm, students. So CBC, sputum examination, chest x-ray, CT chest, fiber optic bronchoscopy. Now fiber optic bronchoscopy is, there are two types of bronchoscopy. One is your flexible and rigid. So fiber optic or flexible is the same. It is generally used for diagnostic purposes. Now if the patient history is suggestive of those minority cases, cardiovascular, systemic, what might be those cardiovascular causes? It can be due to cardiac failure, valvular heart diseases such as mitral stenosis, pulmonary embolism, pulmonary arteriovenous malformation. There can be some abnormal connections between pulmonary artery and veins. Whenever there are some abnormal connections, always abnormal connections will be unstable and weak. They can rupture resulting in hemoptysis. Systemic causes. Patient might be having some coagulopathy, because of that bleeding can happen. Pulmonary renal syndromes such as Goodpasture syndrome. In Goodpasture syndrome, there is involvement of basement membrane because of autoantibodies, basement membrane of kidney resulting in glomerulonephritis and hematuria, alveolar membrane resulting in hemoptysis. Patient will have hematuria and hemoptysis. Then connective tissue disorder, CTD means wherever I write CTD, it is connective tissue disorder. Connective tissue disorders as a part of systemic involvement, they can directly involve the lung, result in lung disease, and that lung disease may be responsible for hemoptysis, CTD related lung disease. And next important is small vessel vasculitis. We have diseases such as microscopic polyangiitis, Wegener's granulomatosis, which will be discussed in your rheumatology. In all those, the pulmonary vessels, small vessels are getting involved, that can result in hemoptysis. Now, if the patient is belonging to this minority group, what will be the important investigations? ECG, 2D echo for cardiac disease. If there is pulmonary embolism, D-dimer will be helpful. For very good visualization of pulmonary circulation, to see a thrombus clearly and any malformation, CT pulmonary angiography. To see whether there is any coagulopathy, coagulation profile, and to look for pulmonary renal syndrome, urine examination. So, urine microscopy to look if there is any hematuria, and specific antibody testing. If there is a connective tissue disorder or small vessel vasculitis, these are autoimmune diseases. Specific antibody testing for autoimmune disease, These are the usual investigations that I advise for minority group. So, in minority group, we go for an ECG, 2D echo, D-dimer, CT pulmonary angiography to visualize the pulmonary circulation, coagulation profile, urine examination to look for any hematuria, specific antibody testing for autoimmune disease to look for any small vessel vasculitis or connective tissue disorder. Now, this is the general etiology of hemoptysis. Now, you are in an emergency department, suddenly a patient with hemoptysis is coming in your night duty. So, how will you approach? So, there is a algorithm for hemoptysis, how it should be dealt in emergency department. So, that I am going to discuss next. So, write down algorithm of hemoptysis. So, you are in your night duty, suddenly there is a patient with hemoptysis, how will you proceed further? So, this will be the algorithm. First thing what you need to know here is, students, is this patient presenting with massive hemoptysis or non-massive hemoptysis? If it is massive, immediately stop your talking with your beautiful co-intern, because if you don't intervene, patient may die here. So, if it is massive hemoptysis, you should be very careful, because there is chances of death. Assess the patient, is he unstable or stable? If the patient is unstable, you should stabilize the patient. you should stabilize the patient and you should immediately call me for a bronchoscopy, and bronchoscopy preferred here is rigid bronchoscopy. The reason for rigid bronchoscopy is it deals with bleed better. It deals with bleed better. It deals with bleed better. We have two types of bronchoscopy. One is flexible and other is rigid. So rigid bronchoscope has a big suction channel. Now what is the benefit of this suction channel, especially in massive hemoptysis unstable patient? So this big suction channel can easily suck out the clots. It can easily suck out the clots and save the life of the patient. So big suction channel can easily suck out the clots and save the life of the patient. It deals with the bleed better. Now if it is a stable patient, you can send the patient to CT chest and later plan for a flexible bronchoscopy. Now if it is a non-massive hemoptysis, you can relax for a while, you can continue speaking with your co-intern, but don't forget to send for a chest X-ray. Depending upon the chest X-ray, you are going to divide the patient into two. Is the chest X-ray normal or chest X-ray abnormal? Chest X-ray normal or chest X-ray abnormal? Now if the patient's chest X-ray is normal, you have to stratify the patient into two groups. Is he belonging to a low risk group or is he belonging to a high risk group? Even though most important cause of hemoptysis is tuberculosis, but when you are going through an algorithm, you should rule out most dangerous cause first. Dangerous is generally malignancy. Why I call it as dangerous? Because even if I miss tuberculosis today and identify after few weeks, the treatment will be the same. But if I miss malignancy today and identify after a few weeks, if it has gone into metastasis, then nobody can treat that patient. High risk are patients at high risk of developing lung tumor. Who are they? Smokers. And second important one is increased age. Previously, age risk factor for malignancy was more than 60 years. Now it has come down to 40 years thanks to air pollution. Tomorrow what will happen, nobody knows. So low risk are generally non-smokers and young patients. Now if the patient is belonging to a low risk group, I should ask him, was it a single episode? Was it a single episode or was it recurrent? Is it a single episode or recurrent? If it is single episode, generally in young, it can be due to some upper respiratory tract infection. So what I am going to do, I will reassure the patient not to worry, and I am going to prescribe an antibiotic. So I am going to reassure and I will prescribe an antibiotic. Now if it is a recurrent episode, I have to evaluate. I go for a CT chest followed by fiber optic bronchoscopy. If the patient is already belonging to high risk, in a high risk, even a single episode I should not neglect. I should go for a CT chest followed by fiber optic bronchoscopy. Now if the chest X-ray is abnormal in the first instance itself, according to new guidelines, here also I should take a CT chest, then I should go for a fiber optic bronchoscopy. Now if you see here students, in majority it is CT chest followed by bronchoscopy. Now what advantage will CT chest will give me before bronchoscopy? CT chest will help you to know the precise anatomical location of the disease. It will help you to know the precise anatomical location of the disease. Now before doing bronchoscopy, if you know that, you will know where exactly to go with the scope, which lobe and which segment. Now what is the benefit of bronchoscopy? Bronchoscope will help you to visualize the segment involved. Now if you find some secretions, you can collect bronchoalveolar lavage. If you find some abnormal tissue, you can take some biopsy, and sending these samples to the laboratory will give you the diagnosis. Once you treat the diagnosis, hemoptysis can also resolve automatically. So CT chest will help you to know precise location. Fiber optic bronchoscopy will help you to collect samples for diagnosis. But if you notice here, in unstable patient, I am not sending him to CT chest, I am directly going for rigid bronchoscopy. What is the reason behind this? Now if I send an unstable patient to CT chest, he will never return back to me, because this patient is unstable, he will collapse on CT table itself. And in unstable patient, my primary goal is to save the life of the patient first. Now here rigid bronchoscopy is not just a diagnostic, it is therapeutic. It is going to suck out the clots and going to save the life of the patient. In unstable patient, so you should save the life of the patient, and rigid bronchoscopy will be more helpful there. Rigid bronchoscopy will be more helpful there. Now you have done all of these measures, but still patient is having persistent hemoptysis. What to do next? So write down, in persistent hemoptysis. In persistent hemoptysis, as a treating doctor, I have two options. So the first option is block the culprit artery. What is the culprit artery? Bronchial artery. I am going to block it. We do bronchial artery embolization. Bronchial artery embolization. Nowadays this is considered as most preferred method. Most preferred method. Now if at all there is a localized disease, consider there is left lower lobe bronchiectasis, always it is getting infected, bronchiectatic lung, destroyed lung, not taking part in gaseous exchange but getting infected and resulting in hemoptysis. In that situations, resection of affected lobe can be helpful. Resection of that affected part of the lung can be helpful. But for all practical purposes, we are nowadays following the bronchial artery embolization only, because whenever you think of doing surgery, it is a major surgery and patient might be having comorbidities, he may not recover from the comorbidities during surgery. So that's why whenever there is a non-surgical method available, that will be considered as preferred method when compared to a surgical and invasive method. Now you should get it down. Why am I frequently doing bronchial artery embolization, not pulmonary artery embolization? There are two reasons, students. First reason, in majority, what is the source? Bronchial artery. And second reason, which artery will take part in gaseous exchange? Is it bronchial artery or pulmonary artery? Your pulmonary artery takes part in gaseous exchange. Now if I embolize or block pulmonary artery, gaseous exchange will not happen and patient will develop hypoxemia. So these are the two reasons why I generally prefer bronchial artery embolization. It is most common source, and unlike pulmonary artery, it is not taking part in any gaseous exchange. Now very rarely, whenever there is a pulmonary artery aneurysm in a small branch, so you can do pulmonary artery embolization for that branch. But right now I have seen more than 1000 cases of hemoptysis. Nowhere it required pulmonary artery embolization. So for all practical purposes, if they ask you which artery to embolize, your answer should be bronchial artery embolization. Now try to solve this case scenario, students. A 54-year-old woman with known endobronchial carcinoma of her left main stem bronchus develops massive hemoptysis while hospitalized. All of the following should be considered in the management except all of the following. So this patient is having a left sided disease. she developed massive hemoptysis. They are asking you which should be considered in management except. See, this is a massive hemoptysis. Bronchial artery embolization can be helpful ultimately. Early bronchoscopy will also be helpful to suck out those blood clots. Then what is this? Placing the patient in lateral decubitus position with her left side down. Is it helpful, students? The answer is yes. In massive hemoptysis, I should protect healthy lung. I should protect the healthy lung by placing bleeding lung down, by placing the bleeding lung down. I should protect the healthy lung by placing the bleeding lung down. What is the concept behind this? Now if you notice here, this is right lung and this is left lung. Now the patient is having a left sided disease. So because of that, all the blood, if you put in left lateral position, the blood will pull up here. So the blood will not be going into the right lung. So right lung will be available for gaseous exchange. So it will buy you some time before you can do some aggressive therapy such as early bronchoscopy to suck out the clots or bronchial artery embolization. By placing the patient with the bleeding lung down, it will not allow the bleed to go into the healthy lung. Because of that, healthy lung will be protected and it is going to take part in gaseous exchange, and it will give you some time before you can do some definitive measure. So this can also be done, but vigorous cough maneuvers will not be advised. Why vigorous cough maneuver should not be done? The reason is simple, students. Whenever patient coughs aggressively, the pressure within the lung will increase and it can result in further rupture of the blood vessels. So vigorous cough maneuvers are not encouraged. Generally we give cough suppressants to this patient. So we calm down the patients by giving cough suppressants also. So the answer here is option B. Coming to some basic histology of the lung. So there are type 1 pneumocytes and type 2 pneumocytes. To understand this, you should know the alveoli. This will be the alveoli, and type 1 pneumocytes are considered as pavement epithelium. Type 1 pneumocytes are considered as pavement epithelium. They cover majority of alveolar surface. They are going to cover majority of alveolar surface. They are going to cover the majority of alveolar surface, and these are flattened epithelium. You can notice. So these are flattened epithelium. These are flattened epithelium. They are covering majority of alveolar surface, and these are vulnerable to injury. Whenever there is an alveolar damage, these can be easily damaged. Now coming to type 2 pneumocytes, these secrete surfactant. The primary function is secretion of surfactant, and by number they are considered as majority in number. Now these type 2 pneumocytes, they are majority in number like this. Majority in number. Type 1 pneumocytes, they are covering the alveolar surface in majority. So covers the majority of alveolar surface is type 1. By number, majority will be type 2 pneumocytes. And these type 2 pneumocytes, they can divide and give rise to type 1 cells. Whenever there is an alveolar damage, type 1 easily damaged. But these type 1 have no capacity to divide. So how are type 1 cells formed? By type 2 dividing. That's why type 2 pneumocytes are also called as precursors of type 1. Type 2 pneumocytes are also called as precursors of type 1. So in simple words, write down this statement from Harrison. whenever there is alveolar injury, whenever there is an alveolar injury, type 1 cells easily damaged, type 1 cells easily damaged, and type 2 proliferation will be seen. Type 1 cells does not have the capacity to divide. So, type 2 cells will divide and give rise to type 1 cells. This is something regularly happening, whereas there are few exceptions, especially in severe diseases such as ARDS. In ARDS, both type 1 and type 2 damaged, because both type 1 and type 2 are damaged, the type 1 and type 2 are damaged, there will be poor prognosis. Previously at least type 2 was remaining and it was replacing type 1. Now, because both type 1 and type 2 cells are damaged, there is extensive damage, and this is one of the reason for poor prognosis in ARDS. So, point to remember, generally it is type 1 getting damaged, type 2 proliferation, but in severe diseases such as ARDS students, both the type 1 and type 2 will be damaged, and this is one of the most important reason why in ARDS there can be poor prognosis.